for those who are unable to attend. And at the end of the session, there'll be information for those people seeking continuing education credit for their attendance at this particular meeting. Would also like to remind folks that the chat is a function that we encourage you to use, and we also encourage you to raise your hands if you have questions during the question and answer period of the discussion. So it'll give you a chance to really interact with the speakers and the discussants who are really eager to present this important information on telehealth, both in rural areas and post-COVID or COVID use during the pandemic. And what you see on the screen here are the learning objectives. I'm not going to read these to you, but basically it's to create awareness and help you understand the issues and challenges and facilitating factors, as well as the patient characteristics of those people who were actively engaged in using this particular technology. Next slide, please. So this is our agenda for today. And as you can see, Lisa Simpson is not here at the moment. I'm Lucy Savitz. So I'm standing in big shoes here. But I do welcome you. We're going to have an introduction by Dr. Benyaz, who I'll introduce in a moment. And then the presentations that you can see listed here of the 2 evidence reports that were done on the topic of telehealth. We'll have some initial reactions by some discussants who have graciously volunteered to be present and react to the content of the reports. Then we'll have a moderated discussion, which I will moderate. And then lastly, some thematic focus questions where we'll ask you to engage in a larger Q&A initiative, and then some closing remarks. So I don't want to take up a lot of time with this business of really sort of getting you prepped for the session. I think that the material that's going to be covered is going to be way more interesting. But to get started and find out about you and your perspectives so that we have a sense of what people are accustomed to with respect to telehealth, the first poll question that we're asking you to respond to is, are you familiar with or have you used an EPC report before? So if you could just please respond to the poll. Just a little bit more time until that closes, and we could get a sense of who's in the audience. We have great participation in the meeting today. We're really excited about it. So Edie, whenever you're ready. And I didn't see the results of the poll. The second poll question is up now. How would telehealth research be most useful to you?
My poll question is still the first one. It hasn't updated to the second.
Yeah, the responses are not up.
Right, and we don't have the ability to, there it goes.
My apologies, there's a slight delay in switching the questions.
So Edie, will we see the results of both questions after this?
I think I can maybe pull it up for the first one, or I can verbally tell you. So for the first question, about 37% were familiar with EPC reports and 26% were not. There was 37% who did not answer.
And have we closed the second poll?
This poll now.
Sorry for the technical difficulties, folks.
There we
Oh,
go.
and we can see the results. So that's really great. So most people are really looking to inform their own research or their practice, clearly. Very helpful. Thank you for taking the time to respond to those. If we could go to the next slide, please. So what I'd like to do now is to, before we move into introduction of the authors, is introduce Dr. Lionel Benez, who's a physician. He's a medical officer for the EPC division of AHRQ's Center for Evidence, Practice, and Improvement. And before coming to AHRQ, he really focused his career on translational cancer research with a specialization in prostate cancer, epidemiology, biomarkers, and health disparities associated with that cancer. I was teasing him on the preparation portion of the meeting before you all came on that he was both a fellow and assistant professor at Duke University. So as we're moving into March Madness, he's a proud supporter of Duke while I was a graduate of UNC, and we're not in March Madness. So with that, Dr. Benez, I'll turn it over to you.
Lucy. Good afternoon. It is a pleasure to introduce our presenters from two of our EPCs that have recently produced high-quality evidence reports of such usefulness to our partner organizations and stakeholders, as well as the discussants who should be able to provide insight into expanding the impact of these reports. Our first presenter is Dr. Elham Hatef, who is Assistant Professor in the Division of General Internal Medicine at Johns Hopkins School of Medicine, where she has a joint appointment in the Department of Health Policy and Management in the Bloomberg School of Public Health. Dr. Hatef is core faculty at the Center for Population Health IT and Center of Excellence in Adult Primary Care. Dr. Hatef's research focuses on use of health IT and big data to assess health disparities in population health. And her CV is replete with funding support from AHRQ, NIH, and the Veterans Health Administration. Our second presenter is Dr. Annette Totten, who is Associate Professor at the Oregon Health and Science University and OHSU PSU School of Public Health. She is Associate Director of the Pacific Northwest EPC. Dr. Totten has been PI on systematic reviews and guidelines on a broad range of health topics, including telehealth, health IT, rural health, pre-hospital care, and brain injury, and her work has been funded by AHRQ, PCORI, and the Veterans Health Administration. Our discussants will include industry stakeholders, Dr. Arshad Rahim, who is an accomplished thought leader on several topics within quality improvement, care delivery redesign, population health model execution, and analytics. Dr. Rahim serves as Senior Vice President and Chief Medical Officer of Population Health at Mount Sinai Health Partners. Janice Tufti, who is the owner of Asana Consulting. She's an active patient ambassador whose work focuses on systems improvement, evidence-based medicine, quality measurements, and clinical guidelines. And Dr. Ann Zer, who serves as the medical director with Indiana Medicaid and is a trusted and reputable internist serving the community of Indianapolis. Presenters and discussants, welcome.
Can I get started? Hi, everyone. I'm Elham Hatef. I first want to thank AcademyHealth and AHRQ for inviting me to present our work. And also thanks everyone for joining this panel. So our review was focused on the use of telehealth during the COVID-19 pandemic. And this is the review that we performed at the Evidence-Based Practice Center at Johns Hopkins. And I listed my co-authors and collaborators as well. Next. So the objective of our review was to assess how to provide telehealth care. And we wanted to identify the characteristics of the telehealth as a mode of delivery, and also the patient population, the setting that the patients received the care, and the setting that the care was provided. We also wanted to identify benefits and harms of providing telehealth versus in-person care, and also we searched for implementation strategies for implementing telehealth services during the COVID-19 pandemic. I have listed the data sources here. Our search included March 2020, the beginning of the pandemic, and it extended all the way to May 2022. We performed a mixed methods review. We included both qualitative and quantitative studies. and for the reviewing of the evidence, including the review of the abstracts and the full text, and also the extraction of the data and the assessment of risk of bias, 2 reviewers independently performed the task, and then they compared their findings and resolved the discrepancies and disagreements. Next. Before putting together our key questions, we developed an analytical framework. We wanted to think about different facts or factors that impacted the use of telehealth during COVID. So we thought about different characteristics of the patient population, the setting that the care was provided, different factors that impacted the implementation of telehealth. We also thought that if we want to look at the outcomes, we should look at both the immediate or intermediate outcomes and as well as longer term outcomes. We also wanted to see if we could identify any evidence on the unintended consequences of telehealth. And also, we thought that the timeline of the pandemic was very important because, as everybody knows, the first few months of pandemic, from maybe March to May 2020, was the period that the telehealth expanded rapidly. We called it rapid expansion period. And then there was a period that started from June 2020, and it probably continues up to now, which is the maintenance of the services, and telehealth was being used at different levels by different health systems. Next. Then based on that framework, we put together a number of different key questions that we wanted to answer with this literature review. The first one was to identify the characteristics of patients, but also providers and health systems that use telehealth. We wanted to see what demographic and socioeconomic characteristics and even geographic location of the patients impacted the use of telehealth. What were the characteristics of providers and health systems that use this mode of care delivery? And how do the patient, provider, and health system characteristics were different between the first 4 months of pandemic, which was the period of establishing the telehealth services, versus the remainder of the pandemic during the continuation of the telehealth services. Our second question was focused on effectiveness of telehealth. So we wanted to look to see if we can identify any evidence about the benefits and harms of telehealth. We looked into whether there was evidence about different types of benefits and harms based on the type of telehealth intervention, whether it was telephone or video visits. We wanted to identify how patient characteristics varied in terms of benefit and harms, and also how provider and health system characteristics changed. In the third question, we looked into what was considered as a successful telehealth intervention, both from patient caregiver perspective and also provider's perspective. And lastly, we looked into implementation strategies at the health system level to basically implement telehealth services. Next. So we started when we did the first search, we ended up with about 13,000 abstracts, about 3,000 of them were duplicates. So we ended up reviewing about 10,000 abstracts. We identified about 2,000 full texts that were relevant to the study. And after the review of those full texts, we excluded a number of them. And at the end, we ended up with 310 abstracts, 310 full text studies that we reviewed, and we extracted the data from them. And I will talk about the number of studies for each of the key questions. Next. For our first questions, in terms of the characteristics of patients, providers, and health systems, we ended up including 11 studies. And the reason that this number of studies went down was that we really were looking for studies that were population-based, and they were really representative of the US population. So these studies that we included in the synthesis of the evidence are really large studies that have included millions of patients. All of them are national. They have included so many different types of health systems. So they would provide a real overview of the characteristics of the patients, providers, and health systems. For instance, the first 2 studies that are listed here are actually the studies that were performed at Hopkins, and they were based on the claims data from Blue Cross Blue Shield, and the sample size was something around 50 million patients, and it was a national study. So that gives you an idea about the type of studies that were included. Next. So in terms of the characteristics of patients, we identified that although the telehealth improved access to care during the COVID-19 pandemic, but the people that got access to COVID-19, much like the users before COVID-19, were mostly young or middle-aged. They were white females, had higher socioeconomic status, and mostly lived in urban settings. And also among the visits for mental and behavioral health conditions were the most frequent visits through telehealth. And the type of care that was provided in a telehealth encounter, mental and behavioral care was the most common type of provided care. Next. Yeah, next. Thanks. So the second question, we wanted to look at the effectiveness of telehealth. So we wanted to identify benefits and harms. So we basically developed a framework for what we mean by benefit and harm. And we looked at the outcomes in 3 different categories: healthcare utilization, clinical outcomes, and process outcomes. For healthcare utilization, we looked at ED visit, hospitalization, and readmission. For clinical outcomes, we consider outcomes like mortality, condition-specific clinical outcomes, patient-reported outcomes, and adverse events. And for process outcomes, we looked at factors like missed visits, case resolution or duplication of services, change in therapy medication adherence, and up-to-date labs and paraclinical assessments. And also because the studies were very varied in terms of the clinical condition or clinical area that they focused on, we categorized them in 5 major categories. We looked at the studies that the telehealth was used to provide care for general medical conditions, either to adults, pediatric populations, or everybody together. Also, the care that was provided for specific conditions, we looked at COVID and also care provided for pregnancy, prenatal, and gynecological conditions separately, and then put all other conditions all together. We also looked at the studies that telehealth was used for surgical care, care for general behavioral and mental health conditions, and then the care that was provided for functional impairment and in physical rehabilitation setting. Next. So in terms of the first category, first of all, we included 63 studies for the synthesis of this evidence. And the reason that the number dropped was that we really wanted to compare telehealth with in-person as the standard mode of care delivery. And there were only 63 studies that made that comparison between telehealth and in-person. So for the first category of outcomes, the healthcare utilization, the difference between people that receive telehealth and in-person care in terms of the rates of healthcare utilization was either very small or it wasn't really clinically meaningful. And it varied across different clinical areas. For instance, for patients that received care for COVID-19 or for women's health, the ones that received initial telehealth visit, they had higher rates of ED and hospitalization. But if we looked at the adult population that received care for general medical conditions, the ones that received initial telehealth, they had lower hospitalization rates comparing to the ones in in-person care. But as I mentioned, the differences were very small. Next. In terms of clinical outcomes, again, the differences between telehealth and in-person really varied by the type of outcome. For instance, for mortality rates and reported adverse events between telehealth and in-person care, we identified that the differences were either very small or they really didn't make any clinical differences. But for the patients that receive an initial telehealth care, we identified that they had better patient-reported outcomes and condition-specific clinical outcomes comparing to the patients that received in-person care. Next. For process outcomes, the story was again the same. The differences between telehealth and in-person varied by the type of outcome. In general, we identified that there was a lower rate of missed visits, change in therapy medication, and up-to-date labs and paraclinical assessments for the people that receive an initial telehealth visits. But the initial telehealth visit also resulted in higher rates of therapy medication adherence. Among patients that received care for general medical conditions or received surgical care, The patients that had a telehealth care, they had lower rates of case resolution, which meant that they needed to go back to the clinic and have a follow-up visit to address their questions or their needs. And among patients that received care for specific conditions, excluding COVID and pregnancy that we looked separately, the people that had an initial telehealth visit, they had higher rates of case resolution. So it was very difficult to make a general conclusion about these findings. And as you see, the differences, there were differences depending on which type of a specific clinical condition we looked at or which outcomes we assessed. Next. The third question focused on the success of the telehealth from patients and providers' perspective. We included 187 qualitative studies and another 138 surveys in this assessment. And we identified that from patients and providers' perspective, telehealth was considered more convenient, and it provided a greater access for patients, and it gave better flexibility to both patients and providers. It was also more efficient in terms of time management and the use of office space for the providers, and allowed the remote work both for patients and providers. And it also provided the opportunity for greater inclusion of family caregivers in the care process. But telehealth might not be suitable for all patient populations, especially the patients that are more difficult to reach and engage. It might be more difficult to use telehealth for those patients. And it might result in some missed or delayed diagnosis because it doesn't have that component of physical exam. So depending on the clinical condition, there might be some missed or delayed diagnosis. Also, telehealth raised some concerns about the maintenance of privacy and confidentiality, especially from patient perspective. The patients that needed to access telehealth from public places, or they lived in home that there were some other people also living there, the patients raised the question about the confidentiality of the services they were receiving. And also, insufficient communication and some technical issues were considered as critical barriers to implementation of telehealth, especially in the longer term. And there were some comments about maybe a combination of telehealth with traditional in-person visit might be a better way of care for some patients, especially some specific patient populations that might live far away from some healthcare systems. Maybe a hybrid type of mode of care delivery would help those patients. And for our last question, we looked at whether there was enough evidence in terms of different implementation strategies at the health system level. And this was the question that we found a very small set of studies for. We identified 51 studies, and there wasn't any study that really directly evaluated or even compared different implementation strategies. And after we did the update of our search and the number of studies in this category doubled, we still had a difficult time to find the specific studies that did that direct evaluation or comparisons of different strategies. And there was also a lack of evidence about telehealth, the cost of telehealth implementation, and also sustainability of services. And also there wasn't evidence about implementation outcomes at the health system level. On the provider side, the telehealth adoption and acceptability was affected by some factors, such as whether the providers had any training in the past or they had any experience with using telehealth. And the ones that had previous experiences, they were more favorable of adopting and using telehealth. And the appropriate of telehealth services in achieving whatever was called as an outcome of that specific intervention, it was very mixed on both patient and provider side. Among the providers, the feasibility of telehealth services was generally high, so the providers were more in favor of telehealth as a mode of care delivery. But for patients, the feasibility was limited by the availability of telehealth technology. So just the access to the technology was one of the factors that the patients identified as one of the barriers for the use of telehealth. So our study, our review had a few different limitations. The first limitation that we faced was that there was really a lack of information on the type of telehealth that was used. There were very few studies that clearly mentioned whether they were using a video visit or a telephone visit, and also how that specific telehealth service was implemented. We find it very challenging when it came to the outcomes of telehealth, because outcomes were defined very broadly, and even for the same outcomes, they were measured very differently across different studies that made the comparison very difficult. For the quantitative studies that we included in the assessment in our review, most of them had very high risk of bias, and the qualitative studies also didn't have a very good quality in terms of their reporting and the method that they used. And also evidence was lagging in terms of, as I mentioned, the burden and cost of telehealth. And also the outcomes that were reported, they were all very short-term outcomes, and there weren't outcomes related to long-term stability, sustainability, and also the implementation issues. Next. But with all those limitations in mind, I want to conclude and say that during the COVID-19 pandemic, telehealth was very broadly used, and the characteristics of patients that used telehealth were very similar to the ones that used any other healthcare services or digital services. The use of telehealth may be comparable to in-person care across different clinical and process outcomes, and telehealth implementation address the need for both patients and populations, although there were some differences in terms of their expectations and the need that it was addressed. And telehealth provided a viable alternative mode of care delivery during the pandemic, and it can show that there is some promise for the future use of telehealth post-pandemic. And with that, thanks everyone for your attention.
Great, thanks. I'm gonna jump right in so I can get done quickly so we can get to the fun part, which would be talking about all of this. So just if someone would put their some up and make sure they can hear me. Someone just wave and let me know. Thanks. I always hate it when I start a presentation and realize I'm 2 minutes in and nobody knows what I'm saying. So as Lionel kindly introduced me, I'm Annette Totten, and I'm with the Pacific Northwest Evidence-Based Practice Center at Oregon Health and Science University. And this review on rural telehealth, provider-to-provider telehealth for rural health, was part of the NIA Pathways to Prevention program, P2P. If you're not familiar with that, if you search NIH P2P, you'll find it. And on that webpage, you'll find the full report that we did. You'll also find the journal articles generated from that. And the way that works is we did the systematic review, and then there was a panel of experts. There was a workshop where people provided other reports, other inputs, and then the panel actually wrote recommendations. And both of those, both our systematic review and the panel were published in the Journal of Telemedicine and Telecare, and the links to those articles are on the P2P site. So please use those as the definitive results, maybe not necessarily my slides. Okay, if you could go to the next slide. So just quick background, as most of you know, rural communities account for 1/5 of the US population, and they definitely experience higher mortality and morbidity. And the reasons are complicated, but at least one reason is access. And telehealth has the potential to improve access, and then we hope quality and ultimately outcomes. And pre-pandemic, it was growing, but slower than most people thought it should have been growing. And then we had this exponential growth during the pandemic. And then currently we're sort of in an interesting place where we're not sure what's going to happen next. And I'm hoping that's maybe one of the things we can talk about, because maybe we have different perspectives on what is happening. If you could go next. So before I start, we just got to say a couple of quick things, because provider to provider telehealth, what do I mean? So telehealth, we use a pretty standard definition about using technology to provide healthcare across time and distance. But I just want to make sure everyone's clear that that's a lot of different modes, a lot of different functions, and a lot of different clinical indications. And I was on a panel with someone else the other day who said something I really liked. He said he hates it when people ask him, does telehealth work? Because it's like asking, do medications work? you know, it's sort of a nonsensical question. Provider to provider, what we're talking about is using the same technology to support the healthcare professionals when they're caring for patients or populations. And we didn't stick to a strict definition of rural. We allowed the studies to define that. If you'd go to the next. So we had 4 questions. One was about the uptake of different types of provider to provider telehealth in rural areas. The second was sort of the stereotypical, traditional systematic review question about effectiveness for rural patients. The third was what barriers and facilitators to implementation and sustainability had been identified. And the fourth was about methodological weaknesses of the studies and what could be done to improve the research. If you go to the next. As you've seen, we do these things where we track all the studies. We'll just go on from here. We don't need to and keep going. So the first question, we didn't find a lot. Now this review was completed. The topic was developed by NIH and it was completed before the pandemic, pretty much before, well, during the pandemic. But most of the research was conducted before the pandemic. We just need to be real clear about that. And there weren't any, we couldn't find any big studies or surveys that gave an overview of the varied uses of telehealth, specifically in rural areas. We did find some regional and national surveys that looked at specific uses: telepsychiatry, emergency, telestroke, and pharmacy. If you could go to the next slide. And, you know, so there's some limited data, and that data did show that telehealth was increasing even before the pandemic. So anyway, then we looked at the effectiveness questions, and we did this by setting to try to put sort of somewhat like studies together. And we looked at inpatient, and there were 12 studies, and most of these were before and after. That is, they measured the outcome, implemented telehealth, measured it again. And as you know, there's some problems with those types of studies, but that's what you most frequently see. And basically, these studies fell into telehealth consultations for rural hospitals. So inpatient, they had inpatient consultations for inpatients versus either the specialist coming to the hospital or doing a phone. And you end up with very similar outcomes, similar lengths of hospital stay and similar rates of transfer. A specific use that had been studied in a couple of studies was keeping neonates at the rural hospital they were born, as opposed to transferring them to a higher level intensive care. And those studies found similar outcomes. And then in remote intensive care units is kind of interesting because there are a lot of studies, but most of them aren't actually in rural areas, which is kind of surprising and maybe something we can talk about later. So next slide, outpatients, we had more studies, 23, and most of those focused on providing specialist consultations to primary care providers, managing patients with diabetes or depression. And there were mixed results, some improvement in some outcomes or no difference across those for patients with diabetes. With depression, you actually do get higher utilization, which is used as a benefit. The sense of using more primary care and more outpatient care when the consultations were involved for depression care. If you go to the next slide. Emergency care is another, with outpatient, the biggest places where we could find studies specific to rural patients and populations. And most of these, a big chunk of these, are using telehealth consultations to assess and treat stroke or heart attack or chest pain at the rural hospital rather than transferring a patient. And when you look at those, you end up with similar rates of mortality and similar time to treatment, which is what you want, right? That the patients could stay at the rural hospitals and have similar outcomes. And then there's another group of studies that look at telehealth consultations by specialists with the rural emergency departments to help make the treatment or transfer decisions. And you find very similar patterns of transfers, whether you have those consults by telehealth or you have them in another format. So education and mentoring studies include ECHO and some other things. And basically the takeaway here is, well, most ECHO programs don't get to the point of patient outcomes. We did find a couple. We did find a study where the patients with diabetes had better A1Cs after their clinicians participated in the ECHO. And we did find a study that compared hepatitis C outcomes with people who'd been in the ECHO versus people at academic medical centers. If you'd go to the next slide, most of the results were about changing provider behavior or knowledge. If you could just go to the next slide. So basically, not surprisingly, as similar to the other, there are several instances where there's effectiveness. There is some evidence, but it's usually, you know, for specific uses in specific settings and specific patients. We didn't find much about harms, and that on the one hand, maybe there are no harms, but on the other hand, it would be nice if people said they actually looked. And then the mentoring programs do seem to work. If you go to the next slide, because I want to talk and keep going. So barriers and facilitators, sorry, back there. We looked at a bunch of program evaluations that used a lot of different methodologies. If you go to the next slide. And then we mapped those barriers and facilitators onto the CFIR model for implementation research, just to get the language consistent. If you go to the next slide. And then we took those CFIR domains and used this Sankey diagram to show how often they were mentioned and whether they were facilitators or barriers. And what's kind of interesting about this is some things, not surprisingly, like available resources could be a facilitator or a barrier pretty equally. And you can sort of visually pretty quickly see, you know, what the facilitators and barriers were. If you go to the next slide. So, the main point, just very fast, is, you know, more knowledge and information and available resources are facilitators. Barriers are also lack of available resources and lack of compatibility with values and workflows. And there may be some that are unique to rural. We did find mention of sometimes the consulting providers not being familiar with the limitations and the populations. And, you know, so their advice was maybe less helpful. There's also problems with rural organizations having the resources and the commitment to sustain these. And then the technology might be tailored for a rare event. And there were some cases where the telehealth didn't work because it wasn't sort of tested and trained on frequently enough. If you go to the next slide. So I'm just going to skip ahead so that we can stay on time. So the methodological weaknesses question, you know, I just want to point out that one of the big challenges is we're talking about using telehealth for very different health services and interventions. You know, it's a wide range, and some comparisons may be totally inappropriate. And while telehealth is designed to increase access, it's not always measuring impact on outcomes. And we don't know if the quality of the services is necessarily good just because telehealth is used. If you'd go to the next slide. Just want to show you a couple things that we looked at. We did find about a quarter of the studies were RCTs, and we looked at how those were distributed across the different settings. If you go to the next slide. We also looked at sample sizes. I mean, you do see some small studies. If you see those large numbers in the EMS, they use trauma registries or stroke or heart attack registries to look at outcomes. Or claims data, Medicare claims data. So there are some larger studies that use those types of data, if you'd go on. And then what is encouraging is most studies these days are multi-site, at least. So we're not having quite so many single site studies, which always raise some questions about generalizability. If you go to the next slide. So one of the problems with this is, you know, we assess strength of evidence, and the methodological weaknesses was what I was just talking about. But what made this literature particularly difficult, and why most things have low strength of evidence, is because the results are inconsistent, or there's variable outcome reporting, and we couldn't pool things. So that was one of the most common reasons for the low or insufficient rating. And then the precision, some of the studies have very small sample sizes. If you'd go, there is also the publication bias issue. Most people seem to only publish things about the telehealth programs that work, but we couldn't really prove that. I want to just bring up one applicability issue, and then I'll be done. One is all rural is not the same, and sometimes we lose track of that. You know, rural Western Oregon looks very different than rural Arkansas, looks very different than rural Vermont. And I think sometimes we sort of try to say that this will work for every place, and it might not. And then, you know, a lot of this particular review, and an issue is that all of the included studies collected and analyzed their data before the pandemic. If you go to the next slide. And so I guess overall, and this is what we're going to talk about now, is there's a lack of agreement about what the important outcomes or goals should be for telehealth. There isn't clarity around that. And there's also a lack of attention to harms and unintended consequences, and limited specific details on interventions. So that's getting better. And we are getting better about being clear what the comparator is. This is the third review I've done on telehealth. And the first one, half the time I couldn't tell if they were comparing to in-person or no care. So I just want to basically stop there so we can get into the discussion.
Great, thank you very much. Fantastic presentations. I'll remind people we are getting questions in the chat. Please feel free to chat questions. But right now we're going to turn to our discussants. And first I'd like to go to Arshad Rahim. Arshad?
Yeah, no, really interesting presentations. I can speak to, in a general level, at our health system, we obviously, within New York City got hit very hard during COVID, and pretty much everything went to telehealth. And I remember in April, in one day, we did more telehealth visits than we did in the entire previous year. What has happened over a period of time is that we have, I think, went from roughly 70% of our visits to less than 5% are now telehealth. I think the part of the reason that we, and we've talked about this internally throughout Mount Sinai Health System, is there was the technological piece, but there's the operations around and the throughput. And we actually, we've been perfecting a system to work in person for many, many years, and have some comfort and some abilities with that. There are clear things like drawing labs, various other imaging that can be done on site, some of that diagnostic that was part of the challenge. But what really surprised me is even getting patients, in the queue. It was a simpler way to go between exam rooms than it was to you be able to use technology and have a waiting room there. I mean, it was very complicated for many of us who even thought we were quite technologically savvy. I would say, though, I think it's like with a lot of technologies right now, I mean, they're obviously the way we've done things in the past. I was recently on a kind of a Medicare administrative contractor panel for remote patient monitoring, which has, some, there's some connection here with be able to manage and care for patients outside of the traditional kind of come to the office, come to the facility, brick and mortar setting. And perfecting and getting better at these technologies and making them operationally really sound and similar from a throughput perspective. Even though I work in pop health, I'm still fully aware that we still have a lot of fee for service and operational efficiency focus, and you have that in both type of reimbursement models. But these things take time, and I don't think it's been long enough for us to really perfect. And I think that some of the outcomes will get better as we get better. Now, one of the big concerns here, one of the things that led to a lot of consistent use the past few years, even maybe not as high as we would have expected, was the reimbursement parity with in-person visits. Now, I know that that's on the table to decrease 25 to 30%, and that will really discourage the use. Now, one area that it may still exist because it's going to make sense for organizations that want to be consumer-centric and provide services in the that also have value-based care aspirations is virtual urgent care. We are looking at rolling that out. So there is essentially chronic disease management, primary care, but virtual urgent care, we're investing pretty heavily that will be a kind of part of our future growth, almost as equivalent as it would be with our brick and mortar urgent cares as well. But those are just a few thoughts. I'll pause there.
Great, thank you. And next, let's turn to Janice Tufte. Janice?
Thank you for having me. So I was impressed with these reports, and a lot of the usual, questions come out, right? That I saw as far as like the populations and who was involved and the questions we have. And I just, for a little background, during COVID-19, I worked locally with the University of Washington and Institute for Translational Health Services, where we helped to provide leveraging funds for research that was coming in, and I was the patient individual that was reviewing them, right? We ended up funding 57. So I'm grounded in what was happening. That took off. And of course, the first case was found here in Washington State. I similarly, at the same time, worked with Healthcare for the Homeless. I was in governance there, and felt very fortunate to be a part, have connections close to the state where we were able to ensure that telephones that had data on them were getting out to individuals with, who are experiencing homelessness, and how to address this. So to keep them in care, contact care, and mental health and behavioral health turned out a clear winner in that area where people were connected that perhaps hadn't been before. And so I obviously see the benefits of telehealth, but also understand, the lack of availability at times. It was very innovative during COVID. And I had a couple comments that I wrote beforehand. And basically, I am involved with the research, and I really feel that to combat some of this, higher SES white women conundrum that we're sort of in, I think we need to support a multidiscipline collaborative RCT and qualitative studies in southern states, tribal lands, rural, suburban, and urban underserved, with patients included and integrated along the evidence generation ecosystem, including development, implementation, and evaluation work. I felt that, both reports brought out about evaluation, right? The lack of evaluation standards, perhaps. And I think that we can address some of that, by developing effective methods for effective comparison interventions, with embedding patient partners for both research and quality improvement strategies, as well as implementation that can provide opportunities for bidirectional education, as well as better understanding equitable real-world evidence methods for evaluation of innovations that are meaningful to patients and providers alike. So something I saw that was not really addressed was, patients' preferences, values, and goals. I did, one of them was provider to provider communication, of course, but that does, of course, trickle down to the patients and caregivers. And I want to thank you, and I'll look forward to any questions.
Great. Thank you, Janice. And last but not least, Anzar.
Thank you so much. I am an internist and I practice in an academic health center, but I think the real reason I'm here is because I'm a Medicaid medical director in Indiana. So I'm a Midwesterner. So we've heard from the East Coast and we've heard from the West Coast, and I'm a Midwesterner. Medicaid medical directors care very deeply about this, and the robustness of your reports is incredibly helpful to us. So really, really grateful to you. And as you have pointed out, rural is not rural. We have ultra rural, we have tribal communities, we have range communities, and we have just plain old rural farming communities, and all have incredibly different challenges. Our colleagues from the states in the West with the most mountain ranges and the most, it takes 6 hours to go see your primary care doctor. Those are the people who really were on the forefront of trying to expand telehealth long before the pandemic, and then it just worsened their abilities. And, in places like North and South Dakota, where there might be 1 or 2 dermatologists in the whole state, we have a responsibility to try to bring the best kind of care we can to our members. Medicaid medical directors care very deeply about fraud, and I think there's already been some concern about fraudulent behavior. We also care about interrupting the medical home, and as a provider, I worry about that. And many people have worried that sort of telehealth may sort of siphon off the easy things and leave the primary care provider with only the most complex, most difficult, which can be incredibly rewarding, but that's not how our system works today. And so it really does provide an incredibly challenging venue when you're trying to pay. Indiana Medicaid, like most places, has seen an incredible uptake in behavioral health telehealth. Again, we worry about connectivity, we worry about quality, we worry about connection. So this is incredible, exciting work. Medicaid patients need this access more than anyone else. They are the most vulnerable. They have challenges with where they live. They have challenges with their access to technology, reliable internet. So we have talked a great deal about disparities that, will telehealth actually make this worse? Will some health systems only want to serve Medicaid patients via telehealth because maybe no-show rates are lower, maybe it's less expensive for the provider to do a telehealth visit. So we, again, very grateful for the robust reports and the real work that you did to try to understand what is most appropriately delivered via telehealth.
Great, thank you. And I think we've got a poll question up next, and then we'll move into general Q&A. So the question is, what do you perceive to be the biggest barrier to widespread use of telehealth? And we'll give you a minute or so to fill out your response, please. Got some really great questions and dialogue going on in the chat. I've been following it. Taylor, whenever you're ready to close, and Edie, show us the results, please. Internet access and bandwidth, important. Digital literacy. That actually relates to one of my questions. So if we could just go to the next slide. Thank you very much for those responses. Let me start with my second question first to Elham, because it does relate to digital literacy. When you looked across the evidence that you were reviewing, it looked like most of the users were primarily white, primarily younger, primarily urban, higher socioeconomic status. And I'm just wondering, do you have any thoughts, or were there any lessons learned that you saw in the literature related to what is digital health equity and how should we address that?
Thanks for the question. I would say that I agree that one of the major barriers to access to telehealth is beyond what the health systems and the providers can do. Like access to any other healthcare services, there are a number of social and, in this case, digital determinants of health that are really impacting the access. But in terms of at the point of care, what can happen, especially in the qualitative studies that we looked at, the healthcare systems that had a better understanding of their patient populations, they knew the population, they knew what their barriers were, they knew the level of their e-health literacy, and they basically developed some services around telehealth were more successful. Like the health systems that had very strong technical support for their providers. And they were able to help the patients to get access to whatever telehealth services that they wanted to use, whether it was a video visit or a phone visit. But they had like a technical team that helped the patient to get access and to use whatever service available. They performed better. But the health system that really rely on the provider at the point of care to deal with seeing a patient virtually in a 15, 20 minutes, and in addition to everything that they need to do, they also need to address all the technical questions. That adds another layer of complexity to providing telehealth services. I would also say, I think there is this understanding that if the health system gets to know their patients, they probably come to the conclusion that now that this country is moving out of, hopefully, the pandemic, there are a lot of different hybrid modes of care delivery, a combination of in-person and telehealth. And a part of the decision about which direction to go, it also depends on what the patient needs or what their skill sets are, or what for a specific occasion that the patient needs to get connected to their providers, what would be the best approach there. So I would go back to the idea that we need to know the patients, and then we need to come up with the models that answer their needs, whether it is at one point is telehealth and another point it might be in person. And also the second question that we answered, like the effectiveness of telehealth, the evidence really helps to understand, maybe it helps the healthcare systems to get an idea of what are the best practices related to the clinical condition that they are taking care of. Like there were a lot of studies that show the acute illnesses or acute medical conditions, when they are taken care of during telehealth, they usually end up with a follow-up visit. But for chronic care management, telehealth was a better mode of care delivery. So kind of deciding based on patients' needs and also the type of services that are required, and developing some best practices around those probably helps to address the problem with equity and disparities in the use of telehealth.
Great, thank you. And Annette, I'm just curious. I know, I actually spent the early part of my career in the Rural Health Center at Shepp Center for Health Services Research. And I know that telehealth has been used primarily in rural areas prior to the pandemic because of the geographic remoteness of those areas. And I'm just wondering, based on the evidence that you reviewed, can we learn anything that may inform provider shortages across the rural urban continuum as we move out of this post-pandemic period?
Well, I think it's been really interesting because I think the questions we have to struggle with the most is what's the staying power, of the telehealth that happened during the pandemic versus the slower growth and the things that were increasing. So if you look at, for example, the use of telestroke and statewide networks that have been set up in several states to, help triage and make decisions about where stroke patients should go in order to maximize time, minimize time to treatment and maximize positive outcomes. And I think, those models are being replicated and you can see the effect in Medicare data. So that's really exciting. But then a lot of the things that happened during the pandemic really, as other people mentioned, are backtracking already. And we're not really sure what the staying power is. And, I worked with a lot of primary care practices on a different research project during the pandemic, and they were devastated, and telehealth was not enough to fix that. And part of it is that some of the things that they really need didn't translate well to telehealth. And that's really where we've got to focus. Like, how do you do team-based primary care with telehealth? A lot of the practices that were very successful at team-based care in person could not translate it quickly to telehealth. And so as soon as they could go back to inpatient care, they did. But on the flip side, there are a group of people who did figure it out and had really good results. And they might never have tried it if they weren't forced. That's the silver lining, right? Don't waste a good disaster. So if we can, and I think that's what some of us we've been trying to do, is find the people who were able to transfer quickly to telehealth and who are continuing, and figure out what are the characteristics of both their organizations and the use that makes it so useful.
Right. Well, I'm going to try and pull out some of the questions because we have some good dialogue and questions in the chat. And I don't know if we can hear from Lewis Hugh. Celia, can you unmute him?
Hello.
Do you want to read your question instead of me reading it on your behalf?
Thanks. So I'm a pediatric hematologist, sickle cell specialist. And so my context is that for certain conditions, for certain patients, and telehealth was extremely helpful. My patients with rare diseases where many people may not know what to do, having access to specialists was helpful. And then there are terrible weather days or weeks in Chicago where it's -10 and nobody really wants to travel. So then it becomes telemedicine versus no care. So those are some of the segments or special situations that may not show up if you're looking at large numbers in studies. Thanks.
No, that is an incredible part of the diversity, and why we need to think very carefully about what we're asking when we ask if telehealth works, and for whom and in what situation. And you almost kind of wish you had different terms for it, don't you?
And I don't know, Elham, do you want to comment? Because I know that you noted the numbers of smaller studies in your review.
Yeah, I would say that we included anything. We didn't have any limit on the number of the patients included in the study. And as you said, it varies a lot. It's very difficult to say what works, what doesn't. And I think that is what we are dealing right now in the literature, that we still need a lot more research in telehealth, looking at the specific scenarios and patient populations, and specifically comparing it to what else is available if we want to talk about the effectiveness of telehealth or whether it should stay around or not. Then what is the alternative in different scenarios for different patient populations?
Mhm. Great. Well, I know, we've been talking about more general application and then for specific conditions. And as we all know, we're experiencing a mental health crisis in our country. And here from Bianca, we're seeing a comment and question that both presentations indicated mental and behavioral health as a primary use of telehealth. I think Janice mentioned it as well in her comments. Do either of your groups, or are you aware of any EPC that's looking at researching further the acceptability and effectiveness of using telehealth for mental health service provision?
I think there's a question Lionel should answer.
Lionel?
Put Lionel on the spot.
Sorry.
I mean,
Lionel, are you there?
if the Wally way, I know in the consult review we did a few years ago, that was a subsection that we did look at.
Mhm.
But I haven't seen patient provider work in that area summarized. And I think I was just answering her comment actually in the chat. I think that's really important. It seems like a logical place because you don't need the physical exam, but we really haven't done enough to figure out how to maximize the relationship that's so important in behavioral health when it's done via telehealth, and make sure that that aspect still works. And I think it's also important to realize that most providers were not trained with telehealth. So to assume that they can instantly translate what they used to do in person, even when it's behavioral health, into telehealth without some more thought, I think is setting them up to fail.
Right. I certainly not an expert in this area, but I know that there's a large amount of variability. And I think, Annette, you noted it as well in your presentation of what actually is telehealth. And I think this is especially true in the mental health and behavioral health space, where there's a lot of apps that are out there that are not necessarily evidence-based. And I'm just wondering what is the spectrum of the most used technologies that you saw in your reviews of the literature? And I would pose that to both of you.
I can answer that. For our review, we specifically looked at the patient-provider communications that are in real time. So it is either telephone or video visits, but we didn't include anything that comes through the apps or different wearable devices. And I would add that, as I said, most of the most frequent visits were mental health, and then most frequent care that provided was behavioral health. And actually, in terms of the development of the relationship between the patients and providers, there were a lot of studies that the patients were happy with, like the virtual development of relationship. And I agree that it also depends on different factors, whether the patient was new, whether it was the first interaction with the provider. But a major part of it is also whether the providers are trained to provide the same services. And I think the challenge with telehealth was that we woke up one day and everybody needed to jump on telehealth and provide whatever they were doing in person. They needed to just translate it to virtual. And I agree that there is like a learning period of what to do virtually and how it is different from in person for the providers as well.
Great. And any comment?
So we did include asynchronous because we were talking provider to provider.
Right.
So we had consults that were in real time. We had consults that were done, through EHRs. We also included transfer of data. So like from the ambulance to the hospital, to make the decisions about stroke or heart attack transfers. And we also did include like echo programs. And there were a couple that were text message based, but most of them were either sort of some video or transfer. And we did see a wide range of different technologies. And that's kind of why we grouped by setting, because we thought the technology is very different if you're trying to set up a system that'll work in ambulances versus in a hospital building or an outpatient clinic.
Very important. We're seeing a couple of chats in here asking questions about specific services. One's on optometry and one's on cancer care. Any mention of those in your reviews?
In our review, whatever services that you can imagine, you could find the reports on that's related to telehealth. I don't say that they all were really doing the comparison with the standard of care that was in person. Many of them were very small, like reports of a few patients, but we saw a very wide range of services from any specialty and any type of service that is provided in the healthcare system, even including like yoga therapy sessions that were turned into telehealth. So it was very broad.
In this review, we didn't find much about cancer. In prior reviews I've done on consultations that weren't necessarily rural, we found a decent amount of optometry and dermatology, but one of the challenges is a lot of the work, it's changing and getting better, but a lot of the initial work in both of those fields was sort of diagnostic accuracy. Do you get the same diagnosis by telehealth as you do by in person? And it doesn't take it to patient outcomes. So then they sometimes get excluded in our reviews if our focus is on patient or provider outcomes and not diagnostic accuracy.
Yeah, and I don't want to negate this issue, and be sure to bring it into the conversation about sort of the patient perspective that Janice brought up. And we have a comment from Nathan here. Our patient satisfaction scores have been much lower for telehealth versus in-person visits. And then below, Annette, I think you made a comment about a veteran. Do you want to repeat that?
Yeah, so I did, for a different project, I was interviewing veterans who received their sleep medicine services from telehealth. And one of them said that it was like talking to his doctor on the space station, and he didn't like it at all. So, I mean, people do have very mixed reactions to the telehealth.
Yeah, Nathan's question, though, speaks directly to that. And what are some best practices to provider-specific behaviors that improve the patient experience? I know, like at Kaiser, one of the things that was happening, that the patient would be talking to their doctor's ear because the physician hadn't been trained in how to position the camera, for example.
Yeah. I know people are working on that. I know particularly most residency programs, because they know this is the direction things are going in, are trying to come up with, and it seems really basic, but things like making sure there aren't people walking through the background and things like that. But I think we need sort of more sophisticated work on how to create connection with people. I mean, all of us suffer with it, with doing all of our meetings by Zoom. You know, we don't chat the same way we used to. So I think that's true for providers and patients as well. And I'm not sure I know the answer, but I definitely think we need more best practices.
Great. And Steve Eichner has an interesting comment related to this. Steve, do you want to comment?
Sure, thank you. You know, one of the challenges, I think, or one of the information gaps we have is understanding the purpose of a telemedicine visit and how that affects usage and adoption. You know, whether you're looking at a medicine refill or looking at specialty care visits, you know, particularly for folks that may have a chronic condition or limited range of motion, for example, wanting the televisit to focus on an injury, say, to an ankle, while getting a camera positioned so that you can actually see the ankle on the televisit is a bit of a challenge. So did you look at any of the data? Did any of your data kind of look at why a televisit was occurring and what supports the patient had in place to kind of help with that kind of camera positioning and the like?
Not yet. I mean, I think that maybe one of the places you could do some really good work in that area is the VA, because the VA has a long history of telehealth programs where the patients aren't always at home. They come to a CBOC and they have a telehealth assistant who's there sitting with the patient and can do those things with the specialist being at a medical center that's remote. So maybe there's some things from that that we could learn and then apply to other areas. But I don't think the studies I've read have been that detailed.
Yeah, and I would not expect that they have necessarily, but I think that's an interesting factor that kind of may help drive what kind of usage is being used, and kind of looking at the success failure rate and hitting those high points where we can use telemedicine effectively, looking at the purpose of visit, or at least equipping patients and providers kind of as a clue going in so that everybody's not surprised in that experience. Like, I got to play guinea pig personally on that one, looking at some specialty care, and I'm a technologist, so I had literally Android, Apple, laptops, desktops, 4 different kinds of cameras, and said, okay, guys, what works? Let's kind of step it all through. And I think that kind of work may be necessary in a lab to help drive some of that experience, to provide both background for patients and providers in what works well and how to communicate to patients in that space. We've been using telemedicine on the public health side quite successfully for televisits and looking at visually observing adherence to drug regimen. And that part is, highly successful, doesn't require terribly advanced technology on either part, clear picture in that space. But I do think that there's some value in thinking about, as we're looking at future research, kind of teasing out or making sure we're addressing some of those considerations.
Great points. Thank you for those, Steve. I see an interesting comment here about what do you recommend to improve telehealth with cardiology? And I know as I scanned tables of contents, I think it was in New England Journal today, they're talking about a new study that was just released that looks at the impact of AI on telehealth and how it's going to improve the digital photographs that are transmitted. But I'm just wondering, especially in the provider-to-provider reports, but also Elham and the patient-to-provider reports that you looked at, were there issues that were raised around the quality of the communication and transmission of data?
We didn't see any. There's an increasing number of studies of, that are very similar to the telestroke model, but a telecardiology model where it's either the ambulance or the ED in the rural area who can communicate with a cardiologist to make a decision about transfer or treatment on site. And that technology seems to work. They don't mention problems with the technology in the studies, and you do get similar outcomes and time to treatment. So that would seem to be an area where things are working. Now, other uses in cardiology past the initial triage and treatment, I'm not as sure about.
Elham, any comment?
I don't remember any specific studies looking at the challenges related to the transmission of the data. And I would also say that the literature is probably not still that developed to look at these very specific questions or conditions. Most of the literature that we identified was in general around the experience that the patients had with technology. Like in the qualitative studies. And I showed it in my presentation that is one of the major reasons that the patients don't feel comfortable or satisfied with the telehealth visit, is because of the technical difficulties that they experience rather than the difficulty of maybe working with their providers virtually.
Great. We've had a fairly lengthy discussion looking at the questions coming into the chat. And I'd just like to return to our discussants for a moment. And I'll start with Anne, if that's okay. And any reflections on what we've been talking about from your perspective?
No, I think they're all really incredibly important for Medicaid as well as other payers and for providers, because early, everybody was sort of waiting to invest in technology, waiting for Medicare to land somewhere. And then Medicare obviously adjusted to the pandemic like the rest of us did. So I do think that it would be very interesting to talk about what what do federal and what policy changes does Medicare and Medicaid agencies, what do they need? That wasn't my best English, I apologize, to promote the appropriate use of telehealth. And so I think I'd like to talk about that for a while.
Mm-hmm. Well, why don't we put a pin in that and hear from Janice and Rashad, and then we'll come back to that, because that was sort of our closing discussion. I think
Okay.
Post-pandemic era and what happens to the regulatory relief and policy needed is going to be really important going forward. Janice, any reflections based on the conversation so far?
Interesting. I appreciate what's been written in the chat. And, you know, there really were a number of successes. And in Washington State, where I received my care at Kaiser, we only have clinics, not hospitals, but we have 28 clinics. So it's very rural in Eastern Washington. And even in the county I live in, we have rural in the county I live in, right? So there's always considerations when we are addressing, you know, the best care, and telehealth was widely adopted in our state. I also served on the healthcare authority. I served on the advisory throughout COVID-19, you know, for going forward and also before. So I was very impressed with the quick uptake. And, you know, a lot of this has to do with, you know, the financial whatever health of your area or your state, as well as buy-in from leadership, right? So, and patient partners and caregivers can provide input. And I was very impressed with how our state really reached out to groups who weren't, you know, necessarily normally heard from, and they were funded how we could, you know, do an uptake with telehealth, or, you know, reach out for care as well as vaccination. So, you know, compared to some places around the nation, I think we were pretty quick. Also, you know, there was a lot of people, BIPOC individuals maybe aren't as, didn't have uptake as much in telehealth, but really that wasn't what we found. And I know in some other areas that wasn't true either. So I just think that, you know, going forward, as I mentioned, to look at, you know, tribal southern states, underserved suburban, rural as well as urban is very important. Thank you.
Thank you. Rashad.
Yeah, no, really interesting discussion and chat. I would say, you know, for us, telepsych has definitely grown and grown, and really see that as, you know, likely just going to be the standard. I do think even the new proposed CMS changes to reimbursement actually do not impact substance use and telepsychiatry, telepsychology as much, or at all. I think that's what some of our policy people are telling us, but will affect other areas. That seems to be the norm. And there's and going to be the standard. The other area just of interest, I mean, obviously there's telestroke, a wide variety of areas, but actually our Department of Ophthalmology, our New York Eye and Ear Hospital, has actually really taken on a lot of teleophthalmology, including even for acute conditions. And I'm not an ophthalmologist, I'm an internist, but was on with our president of New York Eye and Ear, and he was describing a recent study we did with 30 patients with an acute, essentially blinding ophthalmic condition. And we would be able to get the image and get it with enough clarity and then do a telehealth consult. And we believe we saved eyesight in a number of folks. And frankly, obviously, this is just from different parts of greater New York City. This is not a rural area, but it actually made our ability to deliver that care. It really facilitated that and hopefully had some positive clinical outcomes. I think there's, you know, there's plenty of other opportunities, you know, using the various technology. I will say one interesting, when folks were talking about, you know, the difficulty of providers, I think Annette was mentioning that, you know, providers just coming on. Yeah, it took a lot to get providers off of FaceTime and Skype and onto HIPAA compliant platforms, but we think they've gotten there. But yeah, then they have to kind of consistently use it. Those are my few thoughts.
Great points. Well, let's turn back to the issue that Anne raised. And Anne, if I could get you to sort of respond to it a little bit more fully, since you represent sort of the policy perspective here. And then we invite others who want to speak up in the chat, certainly. With the ending of the Public Health Emergency Act and some of the regulatory relief that we've experienced and what we're kind of by hearsay hearing, in terms of reduced reimbursements, what policy changes are needed? What are you thinking about from the Medicaid perspective?
So, and I can sort of speak for my colleagues because we've had a lot of discussion around this. We believe that alignment among commercial payers and government payers will serve providers and patients best. People will have common rules, common understanding, and common reimbursement. In Indiana, our commercial payers have not been as reliable as our government payers in terms of covering telehealth visits, and or they did so for a very limited time. So I think that's really important. And then I think support from these sorts of policy of reviews of the literature really can help drive what payers should value most and which services can most effectively be driven. Because if we know that if we know the technology isn't going to support the service, then it's very difficult. And that it's really incredibly exciting that teleophthalmology can happen. I think it's unlikely that that's going to be something that's going to be easy for all of us to implement anytime soon because of the quality of what you need. So I think what Medicaid agencies would be most interested in is alignment and what is a fair reimbursement? What does it truly cost a health center to deliver healthcare that way? Medicaid members, Medicaid agencies pay for a lot of transportation, and Medicaid members can have struggles keeping appointments. And so the use of something that's more convenient and where your job probably doesn't pay for sick time. I think that I would be most interested in how we could do alignment across payers and then have sort of a true understanding of what behavioral health services can be most effectively delivered. Can you do group therapy? Do you do individual and family therapy? Can you do substance use disorder, depression, seriously mentally ill? So even more granular about the value of different modalities as well as different services.
Mm-hmm. Very helpful. As I listen to you speak, it's sort of music to my ears that you're talking about evidence-based policy making. And we have the two experts who did the literature reviews, and I just wonder briefly from Annette and Elham, what did you see the major gaps in the literature that you looked at that would help inform these kinds of policy decisions?
Yeah. So there are two things I wrote down that I wanted to say when we got to this. One is we don't really have very good information on longer term outcomes for patients and providers. We don't know if they get better at it, if they like it more or less over time, if they get disenchanted. And most of the data is cross-sectional or short-term. Mm-hmm. And I think that's a big gap, that if we're really talking about switching to telehealth, we need some longer term outcomes. The other thing is, our studies, I think this is a situation where I struggle with this one, where research, I think, is failing policymakers and health systems leaders a little bit. We study each use individually, and we kind of have to. But the truth is, a health system leader or a policy person like Anne has to think across all the various uses and decide where to make their investment. And I'm not sure our studies are designed to help them do that, to be blunt. And I think that's something we really have to think about. How do we help think, if you're trying to make a decision, do you do remote ICU or do you do telestroke? How would data help drive that decision? As opposed to just saying, does telestroke work or does remote ICU produce the same outcomes? So those are the two things I think are most important.
Thank you. Briefly, Elham, in the last minutes, any comments?
Sure, I would add to that the literature is still not very well developed in terms of effectiveness of telehealth. We are still trying to answer the question that we know it works in some scenario and doesn't work in others, and what are those specific scenarios that telehealth can be the substitute or can be added to in-person. And I would say one of the challenges is that we haven't identified what the outcomes of telehealth are or how we are supposed to measure it. There have been some work done in the past before the pandemic, defining what outcomes are important and should be measured. But I would say the pandemic changed everything, and the evidence hasn't caught up with the needs, with the research needs of telehealth. We even don't have the proper tools yet to do the proper research related to telehealth, especially when it comes to its effectiveness. And I would also say cost and the sustainability is something that nobody has touched on yet. And we didn't find any evidence, anybody talking about the cost of implementing and maintaining telehealth services for different healthcare systems with different patient populations.
Great. Well, thank you. Thank you, everybody, to our discussants, Arshad and Janice, to our authors, Elham and Annette. Thank you very much for joining us today. I think on the last slide, there's a link for the CME credit, and then the upcoming EPC grand rounds will be on maternal health. And I'd like to just point out that Lionel had a comment in the chat that showed the links to, if you would like to recommend topics for the EPC program to do reports, I'd direct you to that link. And with that, I'll close. Thank you, everybody, for your time and attention today. I think it was a wonderful discussion. Have a great day.
Thank you so much.
Thanks.
Thank you all.
Discussion.